Subbaredi from Hyderabad to take us through the session. So, Dr. Subbaredi, all yours, please. But welcome, all of you. Thank you.
Thank you, sir. I'm Dr. Subbaredi, Senior Consultant Critical Care at Apollo Hospital, Jubilee Hills. I welcome all the delegates for Apollo Knowledge Series from the Apollo Center of Excellence in Critical Care. Today's webinar is about sepsis and septic shock. First, let me congratulate Apollo Center of Excellence in Critical Care team and Professor Ravi Mahajan for conducting this type of academic activity. This is the first of its kind in the country, one talk by the nursing faculty and one from the doctors. So we know the nurses play a vital role in ICU management. They are the backbone for the ICU. To improve the outcomes, we need to train all the ICU nursing staff. And thank you, the team, for this wonderful initiation. And today's topic is sepsis and septic shock. So sepsis has got a very high burden on the healthcare. The mortality is very high, and it's one of the most expensive healthcare problems in the world right now. So if you look at the mortality varies from 28% to 50%, depending on the country, depending on the ICU, depending on the hospital. So the mortality varies from center to center. So today, and then we talk about we have guidelines from surviving sepsis guidelines. These once in 4 years we get new guidelines, and so we got in 2016 we got, and then afterwards again 2020. So we are going to discuss about the latest guidelines and what is the right approach for sepsis and septic shock management. And first, we will listen from the nursing faculty. So nurses play a fundamental role in detecting sepsis and detecting the changes in the physiological observation. And then that's how, and they told they will give alarm to the doctors saying that there's a possibility of sepsis based on the change in the physiological observations. And then if they know the pathophysiology of sepsis, and then if they know the management of sepsis, and the actions will be quick, and then we can manage patients in a better way, and even the outcomes also will definitely change. More than detecting and more than management, they play a very, very important role in the monitoring of sepsis and septic shock patients. We know the most advanced hemodynamic monitoring, which is available in most of our hospitals. Unless you have good trained nurses in your ICU, it is difficult to manage and to monitor these patients in intensive care units. So we have two excellent speakers today, Dr. Meghna Matthew, and then Ms. Kalavati. Ms. Kalavati has 14 years of pediatric ICU nurse in charge. She's working in the pediatric ICU for many years, and then she's got vast experience. And she's going to talk about sepsis on nursing perspective. Over to Ms. Kalavati.
Thank you, Subbaredi sir. Thank you, Usha Banerjee ma'am, our Group Nursing Director, and Usha Prabhakar ma'am, Apollo Hospital Director, Jubilee Hills, and my entire team too for giving me such a wonderful opportunity to share my knowledge on sepsis and septic shock today. Entire my presentations will be extremely focusing on assessment of the patient, diagnosis, and management of the patients with sepsis and septic shock. So coming to the new definitions, as per new guidelines, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. Septic shock, sepsis in which underlying circulatory, cellular, metabolic abnormalities are profound enough to substantially increases the mortality rate. Sepsis and septic shock, which is a medical emergency or life-threatening condition, which occurs when the body excessive response to an infection and causes to damage to its own tissues. Sepsis may progress into septic shock, a body-wide deficiency of blood supply that leads to oxygen deprivations, buildup of waste products in the body, and eventually organ failure and causing death. So without timely treatment, the mortality rates are high. So as per new guidelines, sepsis 2021, the sepsis, terms like severe sepsis and septicemia has been removed. So guidelines has been changing as per the patient demands and outcome of the patient. So what will happen if sepsis and septic shock happen to the patient? So when infection comes to the body, the immune system is overwhelmed and produce cytokine releases and causes the vasodilatations of the vessels and vascular leakage, venous blood pooling will be happen. So which affects
slides inside.
So which
Can
affects
you, yeah, can you put your slides in the presentation mode?
So this one only, I'll conclude. So this.
Yeah.
So this is introduction, sir.
Yeah, go ahead. Go ahead.
So which leads to hypoperfusion and cellular hypoxia and metabolic derangements and finally causing cell organ failure and causing death. If you see sepsis mortality, sepsis is one of the main cause for mortality and morbidity of critically ill patients. Despite of using modern antibiotic therapies and resuscitation therapy, the outcome of the patients will be improved sepsis by using bundles and by early detection and diagnosing therapies. So as per the better access to sepsis bundle along with the reductions in mortality rate showing 0.66% in persons with patient sepsis and septic shock. Coming to the signs and symptoms of the sepsis, patients often does not appear acutely ill. The signs and symptoms, the common signs and symptoms of the patients are fever, the most commonly, and flu-like symptoms, chills, shaking, nausea, vomiting, and mental changes, and fatigue and lethargy. These are the main signs and symptoms of the sepsis. When it comes to organ dysfunction, there will be many systems involved in the organ dysfunction. If you see central nervous system, there will be altered mental status. If you see respiratory, patient will have an tachypnea and hypoxia, low saturation levels. If you see hepatic, liver inflammations will be happen and coagulopathy deranges and jaundice can be identified. If you see metabolic disorders, if you lactose acidosis will be higher, and it can be identified in the ABGs or VBGs, and cardiovascular system patients will have a tachycardia and hypotension. When it comes to renal, so there will be absence of urine output. Hematologically, patient will have a purpura, petachy, and coagulopathy disorders. Coming to the nursing assessment, so health assessments are a key part of nurse's role and primary responsibility as soon as patient comes to emergency or to the ICU or to the ward, and assess the patient from head to toe. So the primary assessment will be focusing on airway, breathing, circulation. Assess the airway of the patient, breathing, assess the breathing and circulation, check the pulses and also tissue perfusion, which includes the vital signs, peripheral pulses, conscious level of the patient, capillary refill, skin, urine output. If you see capillary refill, if it is more than 2 seconds, it indicates the low perfusion level, and also skin will be mottling and cyanosis can be identified in the skin. And urine out, if you come to urine output, there will be a low urine output in the patients, and the nurse should integrate all the assessment findings, obtain a brief history from the patient, assess any care that the patient received prior to hospitalization. So coming to the potential nursing diagnosis in a shock. So nursing diagnosis for the client with shock may, but not limited to the following things: ineffective airway clearance. So if we see the patients will have abnormal breath sounds, crackles, wheeze, bronchi, and patient will have dyspnea, excessive secretions, and signs of hypoxia and cyanosis. If you see ineffective airway breathing pattern, so body cannot get enough oxygen to the body cannot get the enough oxygen, so which leads to bronchospasm, expiratory grunts, stridor, increased work of breathing. When it comes to impaired gas exchange, there will be altered in oxygen saturation level. If you see oxygen saturation will be lower side, and decreased cardiac output when heart cannot be pumped and adequate supply to the all parts of the body. So there will be a cardiac output can be identified in the form of raised heart rate, and also sorry. I'm sorry, sir, some problem with this system.
No problem. Please go ahead. Go ahead.
So decreased cardiac output, fluid volume deficit, altered nutrition less than body requirements. So activity intolerance will be there, and impaired physical mobility. So when it comes to management of the patients with sepsis and septic shock, we'll start with initial resuscitation for sepsis and septic shock. Immediately start 1 hour bundle. Measure the lactate level. Obtain blood cultures before administering of antibiotic therapy. Administer broad spectrum of antibiotic therapy, and begins administer of fluid therapy 30 ml per kg crystal or for any signs of hypotension, or if it is more than lactate 4. Remeasure lactate level, initial lactate level if it is more than remeasure. So monitoring and alert. So monitoring, when come to monitoring and alert, patients will show some sign of patient will show some kind of tachycardia in the form of tachycardia, and also less saturation levels, and tachypnea. When it comes to fluid therapy, patients with sepsis and
excuse me, sorry, I think my slide is not moving, or is it universally a problem? It's not come to the fluid therapy, the slide. It's stuck at the sleep pattern disturbance. Is it the same everywhere, or?
Yeah, it is same everywhere.
Okay,
So,
Sister Kalavati, I think the slide is not moving. You have to move it to fluid therapy. It's
ma'am, is it okay, ma'am, now?
it shows to me sleep pattern. I don't know what sir is, sir.
yeah, it's not moving. It's not moving.
We'll stop sharing and we'll share again, sir. Give us 1 minute.
Can you share it again and put it in the screen mode?
Yes, sir.
Yes, I can see it now.
Now I can see. Yes. Good. Yeah, please go ahead now.
So monitoring and alert. So if patient having any temperature more than 100.9 degrees Celsius, and heart rate more than 90, respiration more than 20, and PCO2 levels less than 32, WBC count if it is any having 12,000 less than more than 12,000 or less than 4,000, altered the mental status and GRBS if it is more than 150, and decreased cardiac output, we should alert the team and immediately we should inform the doctor. So fluid therapy, when it comes to fluid therapy, patients with sepsis and septic shock requires an crystalline fluid therapy challenge, 30 ml per kg. So source of infections, when it comes to source of infection, infection is unknown, and it may be due to pneumonia or bloodstream infection, abdominal infections, appendicitis, diarrhea, and gallbladder infections. If it is any urinary tract infection, catheter-related infection, or due to skin or soft tissue infections. If we see the lab investigations, prior to emergency, we need to send this lab investigations, sepsis profile, RP1, renal function test, serum lactate and blood cultures, urine cultures, APTT, INR, ABG, chest X-ray, and ECG. So antibiotic therapy plays a vital role in sepsis, in treating of sepsis, and broad spectrum of antibiotics are the first line medications, and early antibiotic therapy can be improved in critical outcomes of the patient and should be given within 1 hour period. So glycemic control, blood glucose level to be checked, and hypoglycemia and hyperglycemia can be avoided. Hypoglycemia can have devastating neurological consequences, should be diagnosed on time and treat accordingly. So coming to the nutrition supplements to be start within 72 hours of admission, and to maintain of gut integrity and prevention intestinal permeability, need to start the nutrition supplement to the patient. When it comes to mechanical ventilation, so patients with septic shock might require an intubation or mechanical intubation and mechanical ventilations for optimal pulmonary support. This will enable a work of breathing, metabolic demands of the respiration. So vasopressor therapy is required. So vasopressors may be necessary compensate septic shock. Phenylephrine, norepinephrine, dopamine, vasopressin last track, and uncompensated shock, epinephrine, dobutamine, phenylephrine can be started. When it comes to DVT prophylaxis can be implemented as soon as the patient is in the hospital or in the ICU setup. Low molecular weight heparin, unless it is contraindicated for any bleeding. Intermittent compression devices can be immediately can be processed. And stress ulcer prophylaxis, patient with sepsis and septic shock have a risk factors of gastrointestinal bleeding. Guidelines recommended antacids. We see early goal direction therapy of 0 to 6 hours. Initiate the sepsis when identify the patients with sepsis. Place a central line of CVP monitoring. Initiate broad spectrum of antibiotic therapy. Supplemental oxygen if required. Patient is on mechanical ventilation. Mechanical support can be increase the work of breathing to prevent work of breathing can be added. Mechanical ventilation. If CVP is less than 8, crystallite therapy of normal saline or ringer lactate can be initiated, and 30 ml of per kg bolus is required. And the most crystallite therapies we are using normal saline and ringer lactate. So if CVP is 8 to 12, if it is not maintained, we may need to maintain the CVP 8 to 12. Mean arterial pressure, if it is less than 65, systolic BP is less than 90, place an arterial line. Vasopressor therapy to be started. Non-epinephrine 0.1 max per kg per minute, and dopamine 10 max per kg per minute, and hydrocortisone therapy can be also started. And if it is saturation level is less than 70% in VBG saturation or in saturation ABG in more than 65, start with an hemoglobin therapy. And also if hemoglobin is less than 10, start BRBC transfusion to maintain hemoglobin level more than 10. So if consider intubations, incubation and dobutamine infusion to 2.5 max per kg per minute. So goals achieved, if it is goals achieved, hospital admission, maintain hemodynamic monitoring of the monitorings into 6 hours and recheck the lactate level. So the main goal direction therapy of this is initiate the central monitoring within 2 hours, hemodynamic monitoring, CVP more than 8, MAP level more than 65 mm of Hg, and systolic blood pressure more than 90. Saturation, venous saturation level more than 70%, oxygen saturation 65% in ABG, and urine output 0.5 ml per kg per hour. Monitor lactate level every 6th hourly. Antibiotic within 1 hour period to be given, and give steroid therapy if vasopressors not adding. So we are following sepsis pathways in our hospital. So these are so we have it in MedMantra app. We are capturing the data. So how many patients are coming to the hospital with the identifying sepsis, and after diagnosing the patients, and what time we are sending the blood cultures and fluid crystalloid therapy and glycemic control, at what time we are identifying, and what is the glycemic control and CBP monitoring. If it is the de-escalating of antibiotic therapy, whether it is correct or not, and antibiotic exact time we are capturing here, and when patient is moving from ER to wards or ICUs, it can be capturing, and discharge status. Once patient is discharged, we are monitoring, we are capturing the data of patient's ALOS, also average length of stay per patient, and how many patients are admitting, total number of patients, and total outcome of the patients, and also we are capturing. So this is the way, and for this we are following everything, and sepsis pathway guidelines are more focusing on main assessment of the patient, diagnosis, and the fluid resuscitation, and fluid therapy, and vasopressor therapy, ventilation, and also starting of antibiotic on time, and blood cultures to be sent on time. Thank you.
Thank you, Ms. Kalavati, for that excellent lecture. And as you rightly said, at Apollo Hospital, Jubilee Hills, we have a sepsis clinical pathway, like we had stroke pathway, sepsis clinical pathway. And the JCA auditors, where when they go to the ICU, and then they trace this patient from the emergency to the ICU, and from the ICU to the ward, and then they see whether the patient is getting uniform care or not. To provide uniform care, if you have a good sepsis clinical pathway, and then if they know what they have to do in ER and what they have to do in ICU, and then what we have to do in first 1 hour, and then next what they have to do, what investigations we need to send, and in the ICU what they have to monitor after resuscitation in ER. So you can provide uniform care to the patients. And in those hospitals where there is no good sepsis clinical pathway, we can share our clinical pathway, and then we revise these pathways periodically according to the new guidelines, and then we audit them, and then we see the compliance to the sepsis clinical pathway, which is very, very good. And the compliance is very good in our hospital to the sepsis clinical pathway. And thank you so much for giving the overview of sepsis and septic shock management from the nursing perspective. So any questions? And in the chat box, I think Ms. Gopal sepsis profile. Can you please explain about the sepsis profile? I think he's asking about the investigations, what you do in sepsis. Is there any profile? We don't have any sepsis profile, but what investigations we need to do, it is written in the sepsis clinical pathway. If you have it in the emergency, we basically do RP1, and then we do lactate, serum lactates, and then we do blood cultures. We send blood cultures as early as possible. And then depending on the patient clinical status, we do further investigations, whether to chest X-ray or imaging based on the patient clinical status. And then we do like a CT scan, chest and all, depending on the clinical condition. Otherwise, there is no particular sepsis profile to do for these patients. Any other questions from anybody? Usha Banerjee ma'am, any comments?
Jude, you may have to unmute Ms. Usha Banerjee.
I do not see Ms. Usha.
Okay.
Ma'am is there?
No, I don't think she has joined. No.
Okay. Then if there are no further questions, can we move on to the next talk? Yes. So the next talk is again about the sepsis and septic shock. What is the intensivist role, and what is this dysregulated immune response by the host, and what are the new guidelines, new surviving sepsis guidelines, and then what are the new interventions, and then is there any new molecules, new drugs in the sepsis management? Is there any new vasopressor in the sepsis management, or is there any new monitoring, or is there? So to talk about this, we have Dr. Meghna Matthew. She's Senior Consultant Pulmonology Critical Care at Apollo First Med Hospitals. And over to Dr. Meghna Matthew.
Thank you, Dr. Subbareddy. And thank you, a big thanks to Apollo Center of Excellence in Critical Care for having given me this opportunity. I will move on to my slides, and I think I'll start sharing my screen. I'm taking off my video. Probably at the end of it, I can put myself on again. Yeah, so what I thought of doing today was taking you through the history of evolution of sepsis management and letting you know what we have evolved into eventually. So the idea, whenever we hear of sepsis, what do we think? The first word that comes into our mind is infection. So it's just not infection. Infection, it is much more beyond a simple infection. That is what we call a sepsis. Almost 20 years we have been having guidelines. You can see on the slide that 1991 to 2021, we have got nearly 20 years, and the evolution of the idea of the management of the definition has evolved over so many years. We have made mistakes. We have got to learn new things. The newer guidelines are there. It still got its flaws, but still we got to accept something. The last of all, which has come into existence, is the 2016 Sepsis 3 guidelines, in which they have defined two terminologies. One, sepsis. Second, septic shock. Now, what is sepsis? You can see it on the screen. Life-threatening organ dysfunction caused by a dysregulated host response to infection. And I have the definition for septic shock, which includes a little bit more complex things, which you will understand as I'm going by. Now, if you want to go back and understand where I've got all my contents from, these are the three basic guidelines. If you've got your cameras, you can take a quick snapshot so that you understand what am I talking about. So 2016, we had our international sepsis guideline, following which there was some terminology and some hour bundles coming up into the year 2018, and then we got the 2021 latest guidelines. About 10-15 years back, if you were to ask someone what is sepsis, they would have just told you, a patient has got infection, you got the SIRS criteria, that's it. This is sepsis. You got temperature, all these criteria, if it was there, people would have just defined it as sepsis. We have learned it later that it is just not infection with all these parameters that you call someone with sepsis. There are many more things happening around the patient. You may not have these criteria, and you will still end up missing patient who has got sepsis. That's why we got the latest definition where it says it is a life-threatening organ dysfunction caused by dysregulated host response to infection. So remember 3 words. There is an organ dysfunction happening. There is a dysregulated host response, and then there is definitely a category of patient who have got infection. How do you say organ dysfunction? When you go bedside, you should be also able to tell, fine, this patient has got organ dysfunction. Never mind. It's as simple. You have your SOFA score. If you have your SOFA score and you see that the score has gone up more than 2 points, it goes to say that the patient has got some kind of organ dysfunction. What is septic shock? It is basically a circulatory, cellular, and metabolic abnormalities in septic patients, where in spite of giving fluids, the patient remains in shock. The BP is still low. You would have started the vasopressor therapy, and you will get an ABG, and you will see that the lactate is still more than 2 millimoles per liter. Now, why have we even bothered to define sepsis, septic shock? Okay, mind you, many years earlier, 10, 15 years back, we had a lot of cumbersome definitions. We had sepsis, we had severe sepsis, then we had MODS, we had septic shock. It was making it very confusing. The latest definition, the latest guidelines has just limited it to 2 entities. Remember, it is just sepsis, and then you have a septic shock. We need to define it because, as we have already been talking about it, you saw the sepsis pathway. You need to identify your patients early. You want to initiate the treatment early because the earlier the treatment is started, better is the outcome. Also, you need to have a common language. You cannot tell this person has got UTI, this person has got UTI with a low BP. And that's why you wanted to have a simple term. It is septic shock. You need to have either 2 terminologies, sepsis and septic shock. It helps us to, across the boundaries, you can make, communication much easier. And I'm sure you all would have heard Dr. Subba Reddy at the beginning of the talk. He mentioned very rightly, you still have a major chunk of ICU admission, the leading cause as sepsis. And you see that as high as even today, even though our treatment has improved so much, our understanding has improved so much, the mortality is still almost close to 40%. That's pretty high. Now, going to the clinical case challenge, I have this 46-year-old woman. I thought I'll take it like a case scenario. It's better to understand. Just imagine you got this 46-year-old lady who's a diabetic who presents with malaise, confusion, has got this abdominal pain and fever. Now, these are the parameters on examination. Someone says, yes, she's febrile, blood pressure is low, 74/48, heart rate is 112. You see the respiratory rate is fine, saturation is fine. They also assess a little further, and you see the patient is tachypneic, restless with dry mucous membrane. You see that the breath sounds are normal. But when you examine the abdomen, you see that there is some tenderness and then there is some guarding rigidity, and you feel that the peripheries are warm. Now, is this patient in sepsis? The first question that comes to you. And that's where the role of screening tools come. Remember, I spoke to you initially about SIRS. Now, it has evolved even further. We have got much newer criteria. SOFA, Muse, or whatever your ICU is comfortable with, you can go about. In the left-hand side, you can see that I've got 3 topics on the top. You can see clinical warning signs, qSofa, and SOFA. So very early, very early, when sepsis was just getting defined, people were trying to see the warning signs and say that, come on, this is a patient who has got sepsis. There is altered mental state, and all the systemic examination which you go by, you see that, that's how they were describing sepsis. It's quite tedious. If you sit down, start doing all this, by the time you realize and start reacting, it will be too late. So that's why even simpler variable screening tool which came out was on the most right-hand side. You can see the SOFA variable. Now, SOFA was a little bit more simpler. If you can see here, it has got on the left-hand side, it is written here. You can see respiration, coagulation, liver enzymes, and you have cardiovascular. Basically, 6 systems are being examined. If you have a high SOFA score and you know that more than 2 score, you know that there is an organ dysfunction setting. Now, we are still lazy. Come on, this itself is too tedious for us. We wanted to move on to something even simpler, and that's why qSofa came in. Okay, so this came out very recently. Once this screening tool came, there was huge hue and cry. What is this qSofa? It's very simple to use. You see, the 3 criteria here are Glasgow Coma score of less than 15. Respiratory rate more than 22, and a SBP of less than 100. It was proven as a good screening tool, but in the ICU setting, the role of qSofa will become questionable. Why so? Because you will see that, whatever the patient is admitted with, maybe some other condition the patient was admitted with, maybe it's a COPD patient. You will see that the patient is getting tachypnea. Already the patient is not known to have tachypnea, COPD patient. You will see that there might be a traumatic brain injury patient who's already in altered mental status. So the reliability of using this score became a little doubtful because, most of these criteria will otherwise be seen in many other categories of patient, like in a COPD patient or a traumatic brain injury patient. So where will I use this score? It will be probably out of the ICU setup that I'll be using the score. Probably in a ward setup, you quickly see the hypotension, you see alternate mental status, or there is a new onset tachypnea in an otherwise stable patient who was admitted to a ward care. Probably you can be a little bit more alert. It could be a qSofa. It could be a case of sepsis. Now, going back to my patient, I have highlighted a few points here. I see that the blood pressure is 74/48. I see she's tachypnic, restless, dry mucous membrane. Now, I want to know the next question. Is this patient in septic shock? Now, whatever we do, sepsis, septic shock, we all have understood one thing. We have narrowed down to this important slide for the day, and that is that you have to do all these 5 things at the same time as soon as you diagnose. Sepsis and septic shock are medical emergencies, and we have to understand the treatment, resuscitation, diagnosis, everything goes hand in hand. So if you want, you can take a snapshot again, the most important slide, as I'm reiterating it again. So the first thing, you measure your lactate level, you get your blood cultures going. As soon as the blood cultures are taken, give the broad spectrum antibiotic, ration your fluids. Remember, Kala sister has just told us about the fluid, importance of fluid. You have to give fluids and you have to give vasopressors if the patient is still in shock. Now, I'm going to talk to you about each of these points in detail. Now, you suspect sepsis. Okay, now suppose you got a patient, you did your SOFA score and you're suspecting, you are alerting the doctor, or the doctor is there, he's getting alerted or she's getting alerted that this is a sepsis. Quickly, let's have an ABG done. Okay, so the arterial blood gas analysis will give us an idea of lactate. Mind you, the ABG is just one of the components of evaluation of sepsis. There are many more things. You have to send a complete blood count. You will do a blood culture. You might want to do a renal profile. You want to see the electrolytes. You might want to consider a liver function test for a patient where you're suspecting cholangitis. So probably other investigations are going on, but these particular investigation, lactate and few other things, it's very important because it makes a lot of decision changes bedside. Now, lactate is a good marker of tissue hypoxia. Now, in a patient, where will the lactate, in any patient, you're suspecting sepsis, lactate has got a good importance because higher the lactate, you can probably safely say, yes, my patient is probably in sepsis. But if it is a normal lactate, it doesn't mean that the patient does not have sepsis. So please understand when you're interpreting your lactate. High lactate, definitely you can be sure, yes, my patient has got sepsis, but normal lactate, please don't forget, your patient will be still in sepsis. Maybe in the first few hours, the sepsis is just starting. So normal lactate, do not exclude. The other conditions where you might want to consider where there is high lactate, suppose you have got a patient who's got liver failure. This patient is on an adrenaline infusion for whatever the reason. There again, you can see that the lactate will be falsely high, and that is not because of sepsis. So you have to understand when you interpret your high lactate, you have to make sure that this is a case of sepsis, and that's why the lactate is high. Make sure that you exclude other things are not contributing to the high lactate. The other thing Kala sister was mentioning is you also use your lactate to guide your resuscitation. So as you start giving the fluids, it has been shown very clearly a decreasing trend of lactate. Say the first lactate was 9 and it comes down to 4, 5 at the end of 2 hours. That's a good sign. That means your fluid resuscitation, whatever you're doing, your antibiotic, everything is correct. So remember, the first thing what we have done is we have done an ABG along with the other blood parameters. I will also take off a quick blood culture, and that remains the gold standard even today in diagnosing bloodstream infection. Remember that blood culture is done only to decide the further course of antibiotic, okay? Because it takes nearly 72 hours to get the organism back. And what we have found is, even today, 60% of patients in sepsis or septic shock, they still have negative blood culture. That's quite a large chunk. 60%. That's why you see that, you make a diagnosis of sepsis and you still see that, the cultures have come back as negative. It's very common. Don't be disappointed. It's something very commonly that we see. So I have my patient who was having abdominal pain. I've suspected sepsis. I've done a lactate. The lactate has come back as high. I've started blood culture. I will also start resuscitating my fluid. So resuscitating my patient. Now, why do we resuscitate? What is the role of fluid resuscitation in sepsis? Sepsis is a condition when there is lot of vasodilation happening for whatever the reason. There is lot of inflammatory markers being released. It all, it makes the vessel, our venous system, it all dilates up. So there is relative decrease in the blood volume. There will be reduced venous return. Thereby, there will be decrease in the cardiac output. If the cardiac output goes low, what will happen? Ultimately, the tissue perfusion will reduce. That's why your patient will start getting drowsy. You will see the patient is encephalopathic. You will see the peripheries are cold. So all this gets explained. That's why you're trying to resuscitate the patient. You're trying to increase the blood volume. Now, Kala sister was mentioning about 30 ml per kg. Yes, I agree 100% with her. 30 ml per kg is the ideal amount of fluid which has to be given. Now, why this number 30 ml has come? It is just based on observations. Multiple studies, they had seen the patient. They saw how much fluids was given. It was coming roughly to 30 ml per kg. So that's how the number 30 ml per kg. So when you receive your patient, say you are there bedside managing the patient, go ahead, do the blood test, do the lactate, do the fluid resuscitation, get on with your blood culture. Now, if you were to ask me why not 20 ml per kg, 10 ml per kg, I'm sorry, we don't have any data so far on that. Now, when you're trying to resuscitate a patient with fluid, you are actually, as soon as you're there bedside and you're suspecting sepsis, the rescue phase is the optimization phase is the most crucial time period. Rescue is when you give that 30 ml per kg. Okay, you're trying to reverse the hypoperfusion. Optimization, I'm going to talk about it in the next slide, is after you give the 30 ml per kg, you're wondering, should I give more fluids or not? That's what we're coming to. We're trying to understand, should I give my patient more fluid or not? And that's where the optimization phase sets in. Stabilization, de-escalation, these are all phases which is setting in probably post the second day. Now we are all aware, more the fluid, more the harm. Do not give a lot of fluid. You have to be rational in the fluid use. So coming to the dynamic measures, I told you, we suspect the fluid sepsis, you give 30 ml per kg. The later half of the resuscitation will depend upon your dynamic measures. Now, what is dynamic measure? Let me have the simple slide for you. Now, if you have a center where you have cardiac output monitoring, you can measure your pulse pressure variation, you can measure systolic pressure variation, it's easy. Basically, what you will do is you will give fluid and you will see if your parameters are improving, if the PPV is improving, systolic pressure is improving. So if these are improving, that means I can give some more fluids because we don't want to misuse fluid. Now we know that overzealous fluid administration results in pulmonary edema. It can cause intra-abdominal hypertension, prolonged ICU stay, prolonged mechanical ventilation. That's why we are trying to be very judicious nowadays in the use of fluids. Remember, please remember, after the 30 ml per kg, be very judicious. Say you don't have any of this advanced monitoring, what you can do at the bedside is a simple passive leg raise maneuver, nothing. Your patient would have been in this position in the left-hand side, as you are seeing here, 30-degree elevated, put the head and down, elevate the leg in this position. And what you're trying to see is when you're trying to autologous transfusion of the blood, you're trying to push back the blood from the legs and from the abdomen back into the heart and trying to see if that is improving the blood pressure. Okay, here the advantage is without exposing the patient to additional fluid, you're trying to do this and trying to make a sense. Can I give some more fluids or not? Say you do this, you have elevated the leg and the system, you see that the pulse pressure variation, you have your arterial monitor there and you see that the pulse pressure is actually improving. You can be confident, you can give the patient some more fluid. So you have window for giving some more fluid. So 30 ml per kg, that is the rescue phase. Optimization, you go ahead and do all your dynamic measures, and dynamic measures include these kind of maneuvers, passive leg raise, and you can give some more fluids. Role of heart rate, central venous pressure monitoring, and SBP and all have now become very poor indicators. So do not guide your fluids just because you see a tachycardic patient. Every tachycardic patient need not be fluid responsive. Every low CVP patient need not be fluid responsive. So be very careful. Do not give a lot of fluids. You can also use something called capillary refill time. I'm sure all of you are aware of what is capillary refill time. So there was this recent study which showed that, yes, what you can do is check the capillary refill time. If it is prolonged, you can consider give some more fluids. And they saw that it was actually doing as good as the lactate guided resuscitation. So remember, I told you initially, you will give fluid and you will see that the trend of dropping lactate. Now, something else what you can do is capillary refill time. Now, this is the learning curve. It's not yet been strongly recommended. Take it with a pinch of salt because, for me, the capillary refill time may be 3 seconds, but for someone else, the capillary refill time may be 5 seconds. So we have to be a little cautious regarding it. Now, whatever you're doing, you need to have a target. I'm wanting to give fluids, but what am I targeting it to? So what was shown is you're targeting to a mean arterial pressure of 65 millimeter mercury. On the left-hand side, you can see that there is a graph. So much earlier, everyone was giving a lot of the target of mean arterial pressure was 85 millimeter mercury, but someone actually sat down and then we decided to compare 85 with 65. And what we have seen is 85 or 65, there was no difference in survival. So rather target your fluid resuscitation to achieve a mean arterial pressure of 65 millimeter mercury. What was happening is when you're targeting a higher mean arterial pressure, more fluids will be given. You will try to give more inotropes, so thereby resulting more harm. So now we know that stick to 65 millimeter mercury, more than enough. So I'm just recapping it again, everything again. Suspecting sepsis, you can use your SOFA score. Once you suspect SOFA score, send off all the investigation, lactate, blood culture, fluid, antibiotics, and your target, obviously, mean arterial pressure. Now, 65 millimeter mercury. Now, sometimes you will see that, you might want to consider a higher mean arterial pressure target. That would be around 85 millimeter mercury, especially for patients who are chronic hypertensive. You will have an elderly man who's always had a higher baseline. So in those category of patients, try to have a higher mean arterial pressure of maybe 75. Now, I've been telling you all about resuscitate. Now, what do I resuscitate with? Now, the current guidelines, 2021 SSC guidelines have mentioned that we have to stick to crystalloids. You can use isotonic. A balanced crystalloid salt solution is what is recommended. What about colloids? A big no to colloids. No starch, no hexastar, no gelatin, definitely no. But definitely albumin, yes, maybe you have given already like 30 ml per kg and then you are still giving, you see that your patient is still responsive to the dynamic, you did the leg elevation, you see that the BP is improving, you might want to consider, you feel that you have to give some more fluids, maybe consider albumin, but do not target albumin resuscitation to the absolute serum albumin level. Don't aim to improve your serum albumin level. Now, these are taken from my other talk. I've given talk somewhere else and these slides are from there. So you will be wondering, why am I talking about balanced crystalloid salt solution? Multiple studies had come into existence and they were trying to see if ringal lactate or plasmalite is better than normal saline. And what was shown was definitely ringal lactate tends to do better than the saline solution. Now, on the right-hand side, if you can see, I'll make the slide very simple for you. You got this major adverse kidney events, okay? That is MAKE. You see that in the category who got balanced crystalloids, this amount, the number of patients who got kidney injury was less as compared to saline. That's why we are saying that now, if you want to start resuscitating, say you're given 30 ml per kg of normal saline, after that, switch to balanced crystalloid salt solution. Go for ringal lactate, plasmalite, whatever your unit has got. Okay, so this was a meta-analysis. Again, to make this interpretation easier for you, on the right-hand side, you can see the red, the pink, everything is favoring the balanced fluids. So now we know we have to go for balanced salt solution. Now, I've been telling you to take blood culture, start your antimicrobial therapy. Remember that you have to give it in the first hour of recognizing sepsis. Do not delay your administration of antibiotics. So you see the red, I've written there something in red, whatever the alphabets, red, in something in red. It mentions that for every additional hour to effective antimicrobial initiation, suppose you delay your antibiotic, okay? Suppose you're after, say the patient has gone into shock, and if there is delay, the more you delay, every hour the mortality is rising by 7.6%. You can see on the right hand side, you can see that every hour, the more you delay, you can see the odds ratio of death is going up. The chances of dying increases. That's why you have to start in antibiotics very early. Now, this is as per the Surviving Sepsis Guidelines 2021. At any point you're suspecting sepsis is definite or probable, give off your antibiotic immediately within 1 hour. Do not delay. Sepsis is suspected, give it off. Sepsis is less than the possibility and shock is also not there. Say you're suspecting, you're not very sure, a little confusing case, and you see that there is no hypotension, maybe as late as 3 hours you can delay antibiotic, but by then you should have had you should be very certain at the end of the 3 hours, is this a septic case or is this something else? So remember, whenever you're suspecting sepsis, And whenever there is shock, irrespective of shock present or absent, give off the antibiotic in the first 1 hour immediately. What choice of antibiotic? It has to be a broad spectrum of antibiotic. How do you decide your antibiotic? It's a very confusing topic. Every time you're like, what antibiotic should I give? Everything depends upon what is the source of sepsis. Now for lung, you may not want to give the same antibiotic what you're giving for the kidney, or you may not want to give the same antibiotic for the gallbladder, cholangitis. So every source will make a difference. It depends upon the patient. Say you have a patient who has got immunosuppression, who has been on transplantation, those kind of patients, you will want to be a little broader spectrum of antibiotic. It also depends. Say your patient was recently discharged from a hospital, comes back to you within a month. Again, the risk of multi-drug infection resistance is very high. Anytime within 90 days. So whenever you see a patient, you suspect sepsis, say the patient has come to you in the recent time. If it is within the past 3 months, you would have to consider using a drug resistant, multi-drug resistant. You would want to consider covering for multi-drug resistant organism. When will you give antifungals? A big question. Always we are like, should I give fluconazole? Should I not give fluconazole? Very simple. There are few criteria here. Suppose it's a case of abdominal perforation, some, hollow viscous perforation is there, or the patient already got recent antibiotics, someone on total parenteral nutrition, or, there are scoring systems for the same. I'm not going into it right now, but there is something called Candida in the, index is there where you suspect, you put the score and you see the score is high, you can add the antifungal. Suppose your patient is in shock, go for echinocandins. You would have heard anidulafungin, micafungin, you would have heard caspofungin, or you can consider using liposomal amphotericin B. The patient is not in shock, does not have hypotension, you can stick to your fluconazoles itself. Now, we were discussing in the previous talk, what is the sepsis profile? Yes, Dr. Subbareddy sir was mentioning about the different tests that we do. Something else which you can consider doing is procalcitonin. Now, remember that procalcitonin should not be the test which you depend on to decide does my patient have sepsis or not, because it has its own difficulties. It takes a very long time to peak. It might reach the peak only by 24 hours. And there are different categories of patients where it may be negative. So you be cautious. Say a patient was already on steroids, the procal may be falsely normal. So you have to take it with a pinch of salt. Where will you use procalcitonin in the ICU? Now, procalcitonin can be used to de-escalate your antibiotic or to discontinue your antibiotic. Whenever suppose you started antibiotic and 7 days have completed, cultures are negative, and you see the procalcitonin has come down normal, stop your antibiotic. So you can use procalcitonin. So use your procalcitonin only to discontinue the antibiotic. Never use it to start or decide that patient has got sepsis or not. So the current recommendation is, it suggests against using procalcitonin plus clinical evaluation. You have to have both going hand in hand to decide should the patient be started or not. Remember to always have a robust de-escalation policy. Don't try to cut the reason why we are worried about de-escalation is we know that there is a lot of emergence of resistant bug in the community now. As early as possible, say a culture comes back, with a sensitive bug, very simple antibiotic can be given, blood culture sensitivity report has come. So you consider de-escalating it as early as possible. Okay, now the last point in green, restricting antimicrobial therapy to the shortest course. Now, try to have as short a course. Do not give a prolonged course of antibiotic. Why so? Now, this was a meta-analysis. Again, they compared in multiple patients, in pneumonia patients, bacteremia. You can see if you give 8 days versus 15 days, there was no difference. So try to cut down the course of your antibiotic to as low as somewhere between 7 to 10 days, not extending beyond that. You know now that there is no difference, whatever it is. If it is a pneumonia, bacteremia, intra-abdominal infection, urinary tract infection, try to have a short course. However, this may not be applicable to patients. Sometimes you will have osteomyelitis, endocarditis, you will have invasive candidiasis, fungal infection. There, the course of antibiotic is definitely longer. Okay. Now, coming back to my patient, I have started lactates. I have checked my lactates. I've taken the blood culture. I've given the antibiotic. I've given the rescue dose of antibiotic, fluids, 30 ml per kg. I still see my patient is still hypotensive. What do I do? Very commonly, you have done everything and you see the BP is still low. That's where the role of vasopressors and inotropes come in. What do they do? Remember, sepsis is a condition in which there is loss of sympathetic tone. I remember I told you, for some reason, for all those inflammatory mediators, they make your system a little venodilated. Okay, so when there is venodilatation, you will want to act in the reverse direction. You will try to constrict the venous circulation. so that you can achieve a higher pressure. Okay, so that's where the role of vasopressor. Kala sister has already told you. Surviving sepsis guideline to the 2021. First choice is norepinephrine. Always start septic shock. Norepinephrine is a first-line vasopressor. It has clearly shown survival benefit with lower risk of arrhythmias as compared to dopamine. Say you have already used norepinephrine. Your patient has reached a maximum dose of 50 mics per minute. What do you do next? Yes, you can consider adding vasopressin. Okay. Now, septic shock is a condition where you have relative vasopressin. Vasopressin also, remember, it's a hormone again. It is very important. It also helps to maintain your homeostasis. So if you have a vasopressin deficiency, you will add vasopressin. Now, vasopressin, when you start as an infusion, it is a fixed dose. It is not like norepinephrine where you start 1 ml, 2 ml, and then you go up. Here in vasopressin, it's a fixed dose. It's 0.03 to 0.04 units per minute. Okay, so it will come to roughly around 1.8 to 2.4 units per hour you will be giving. Now, say you have started norepinephrine, you have started vasopressin. Very typically, I'm sure all of you would have seen patient is still in shock. Yes, next you will start epinephrine. Phenylephrine can also be used. Now, phenylephrine is a pure vasoconstrictor. You will consider using it whenever you see a patient has got extreme tachycardia, heart rate is 150, 160, because already norepinephrine, epinephrine is going on. You might want to consider using phenylephrine. Dopamine, it's a big no right now. Now, dobutamine. Now, where will you use dobutamine? It's a big doubt. When should I use dobutamine in sepsis? Whenever you have a septic shock patient, you have started norepinephrine, epinephrine, vasopressin, and you have demonstrated that the patient has also got cardiac dysfunction. You do an echo, you see that the patient has also got a poor functioning heart. You can consider starting a small dose of dobutamine. It's always in addition to norepinephrine or epinephrine. Now, there are newer drugs in the block. There are a lot of new drugs which is coming into existence, Celepresent, Angiotensin 2, and a lot of other things which is coming in. So all of these are still in the trial phase, not yet part of the recommendation. So let's wait on it right now. So if I were to summarize my septic shock patient, I will start after the fluids. I will give 30 ml per kg. Further fluids depending upon dynamic indices, one of them being that passive leg raising maneuver I will do. As I'm doing that, if the patient is still in shock, I'll start norepinephrine. I will target a MAP of 65, except in patients who are chronic hypertensive, I will target a higher MAP of 75 to 85. Consider putting an invasive arterial blood pressure monitoring, very useful, because what happens is most of these patients are in extreme shock. The NIBP, the non-invasive BP monitoring, is very unreliable. So you consider it placing it very early in the presentation itself. Now, central venous access, I know that Kala sister has talked to you about central venous access, central venous catheter. Now the recommendation is you need not place it necessarily unless you're able to have a good Benflon place, anything above your antecubital fossa, any good 16 to 18 gauge above your antecubital fossa, you can place a peripheral line and give. Suppose your norepinephrine is going on increasing, epinephrine you're adding, then consider placing the central venous line. Role of dobutamine, remember, never use dobutamine alone in septic shock. Patient can have severe hypotension. Always after starting norepinephrine, epinephrine, and you have shown the patient has got cardiac dysfunction, start dobutamine. Now coming back to my patient, I've done all of this. I've done norepinephrine, I've done vasopressin, I've taken the cultures. Still, I see my patient is drowsy. I see, yes, the BP is a lot better. I get a MAP of 65 now. I see saturation is still good, holding on. Now I see that ABG is showing still metabolic acidosis. Now ABG interpretation is totally different topic. Let me just tell you for now, less than 7.35 means acidosis. So this patient has got acidosis. Okay, 7.24 is the pH right now. The lactate is also high here. What next? What will you do? That's where the role of steroids come in. Now, when do you add corticosteroids? Now, the role of corticosteroids is to downregulate the maladaptive inflammatory response, which we usually see in sepsis. Also, in sepsis, we see that the internal steroid hormone is not getting generated. So that's why you're trying to replenish it by giving extra corticosteroids. Preferred steroid is hydrocortisone. Give it in the dose of 200 milligram per day, or you can give it 50 milligram in 4 divided doses, or you can give it as an infusion. Say you have a erratic sugar control, you go for the infusion rather than giving bolus. That's the only difference between infusion as well as the bolus dose. What they found was whenever the steroid was getting added, once you add steroids, the dose, the requirement of norepinephrine was coming down. Now, corticosteroids in sepsis, when you go back and read the guideline, you will say that weak recommendation. That's because Mortality wise, it does not show much difference. You don't see much difference in the mortality, but what you see difference is the ICU length of stay has come down, the requirement of norepinephrine. The moment you start giving steroid, the norepinephrine requirement infusion will come down. So that's the only rule. Now, after I started my hydrocortisone, what would I do next? Yes, you might want to call in additional help. Say if the patient has got cholangitis, the patient has got renal abscess, you will want to call the concerned specialist, try to have the source control done. Traditionally, sepsis management was thought to be first give antibiotic, then slowly epinephrine, fluid, and all that. Now we know it's not like that. Everything will go hand in hand. You have to start your ABG, you have to get your blood culture, antibiotic in the first 1 hour, you have to start your fluid, you have to start norepinephrine. Everything goes hand in hand. You cannot wait one after the other because it's a golden hour. Critical care is all about golden hour. Just like trauma, just like stroke, sepsis is also all about golden hour. Now, some few additional things which is started into the usages about the role of IVIG, blood purification techniques. Sorry to say, we don't have very good evidence for the same. All are low quality trials and very small center, very small number of patients. So we don't have enough evidence to go for the blood purification techniques. Having said that, if you're doing it on for it's part of a research or some studies going on, we are using it to see what additional advantage we are going to get in future. Now, Kala sister has already spoken to you about housekeeping in sepsis. Remember, transfusion, very common practice. You'll be very tempted to give blood transfusion. No, hold it off. The transfusion trigger cutoff is 7 grams per deciliter. Anyone less than 7, consider giving blood transfusion. More than 7, you don't have to. 2 indications where you will give transfusion even if the hemoglobin is 7 is acute coronary syndrome or chronic cardiovascular disease patients. They do not tolerate hemoglobin 7. For them, you target a higher hemoglobin of say 9 to 10. Now, they are also based on evidence. You have this very famous 1999 TRIC trial and the TRIS trial. TRIS trial was especially in septic shock patients. So this talk is all about septic shock. Now we know in septic shock, you still stick to 7 grams per deciliter unless patient has got acute coronary syndrome or chronic cardiovascular disease. Do not target a higher hemoglobin. What about stress ulcer prophylaxis? Yes, a big yes to stress ulcer prophylaxis. All the more if the patient is on mechanical ventilation, your patient is coagulopathic or has got prior history of acid peptic disease, you might have to consider stress ulcer prophylaxis. Venous thromboembolism prophylaxis. Now, very typically what we see is your septic shock patient or sepsis patient will have thrombocytopenia. You will have a deranged coagulopathy. You will see an high INR. So we'll be like, no, anyways, INR is high, the platelet is low. Why bother about venous thromboembolism? Remember, sepsis or a septic patient or a sepsis patient is not like just because the parameters or blood parameters are suggestive the patient can bleed, the patient will necessarily. They are a very different heterogeneous category of patients where you see that even though parameters will be like thrombocytopenic and raised INR, they will be still coagulopathic. They will actually clot inside. So get going with your mechanical compressive device. If there is no other contraindication, please feel free to start the low molecular weight heparin over unfractionated heparin. What about glucose control? Yes, you have to see all this housekeeping, all this, even though they are very simple things, they actually improve the outcome of your patient whom you are managing with sepsis and septic shock. You need to have your sugar tightly regulated, 140 to 180. What will happen? More than 180, again, the sugar is high. It's a good nidus for a sepsis to set in. So go for 140 to 180. Especially in patients with shock, preferably measure the arterial blood gas. Do not rely upon the capillary blood glucose because the shock patients, all the capillaries will be totally constricted. You cannot rely on the glucose. What about feeding? If your patient can be fed, start early within the 72 hours. I'm sure your ICU will have protocols mentioning 25 kilocals per kg. If you're not able to meet up to that, at least go for tropic feeding. Tropic feeding means at least 10 kilocals per kg. At least try to give 600 kilocals. Now, don't be in a hurry to start parenteral nutrition in ICU. The recommendation as per multiple societies, Aspen, Canadian, and every other guidelines, what they mention is you can wait as long as 7 days. Suppose you're not able to feed the patient, there is some delay, the patient is not tolerating, you can wait as long as 7 days. But by 7th day, have a final call. Can I put a patient on enteral feeding? If not, go for total parenteral nutrition. And with that, I would like to take questions, if any. Thank you, Dr. Subbareddy, sir. Over to you.
Thank you, madam, for that excellent talk. You nicely covered about the new guidelines, definition, and how to identify and what is the management and what is the role of cultures, what is the role of antibiotic, what is sepsis profile, what investigations we need to do, and then what type of monitoring is required. And the fluids, definitely the fluids, the role of crystalloids, colloids, balanced salt solutions, and the new modalities, new therapies. You covered almost everything in your talk. Thank you so much for that excellent talk.
Thank you, sir.
Any questions from anyone? So I can see one question from the chat box.
Okay,
So
sir.
Dr. Rajkumar is consultant critical care from Hyderabad. He is asking, can you elaborate your way of doing passive leg raising tests? Simple lifting of both legs simultaneously or through electronic bed adjustment? How do you avoid technical errors related to leveling of arterial line transducer during passive leg raising test?
Okay. Dr. Rajkumar, thank you for that question. So basically, the problem with the electronic bed adjustment, what we have found is the patient slides down. So you will not be able to achieve 45-degree. And also what the recommendations is, in fact itself, is you have to lift up both the legs simultaneously. You actually have to work your way down from 30-degree elevation. Your patient would have been already in 30-degree elevation. You bring down the patient to flat position. Then you lift up both the legs simultaneously. I agree with you certainly that as we are leveling, all this adjustment is going on. If you have an invasive arterial monitoring, you will have to level the patient. You will have to put the transducer in such a way that, again, you will have to level it to the phlebostatic axis. I certainly agree with you on that. And wait for 60 to 90 seconds. So at the end of 60 seconds, what will happen is the autologous transfusion will happen. It will increase if you have a cardiac output monitor, well and good. Otherwise, with the invasive arterial monitoring itself, you will see what will happen to your pulse pressure changes and you can interpret. Now, what they say is you're trying to autologously transfuse blood from the lower limbs as well as from the abdominal compartments. The biggest technical error, as you rightly picked up, is regarding the arterial transducer. You will definitely have to re-level it to the phlebostatic axis. I certainly agree with you. There are categories of patients where you would not be depending on this, especially patients who have got intra-abdominal hypertension, whatever, say pancreatitis. Then you probably cannot be very clear. You cannot use these techniques to depend and rely on your PLR on this. Electronic bed adjustment, back to that, yeah, it may be, if possible, we can do it, but the problem is your head end also goes down. So you will not achieve that flat end, the head end may not be flat as we want it to be. So I would still go with the manually elevating both the legs.
And then Dr. Rajkumar, any pain, cough or discomfort and awakening the patient during passive leg raising test will definitely provoke adrenergic stimulation, and it can falsely elevate the heart rate and the blood pressure. So we have to be careful, and then you cannot do it from supine position. You have to do it from semi-recumbent position, and then you have to adjust your transducer to the phlebostatic axis is very important. And then the way you do your passive leg raising test is depending on your hemodynamic monitoring, whether you have stroke volume variation, whether you have cardiac output monitoring, or you are just dependent on your the blood pressure and heart rate monitoring. It depends on the type of monitoring you have in your ICU. And a lot of appreciation for both the speakers and everyone is writing in the chat box that excellent presentation, both the speakers, very detailed presentation and a very informative session. And Dr. Ravi Mahajan sir is asking, can you please stress on the first golden hour?
Yes, sir.
What should be prioritized during this time that will have impact on the outcome?
Yes, sir. So I'll just go back to my slide again. I don't know if it is still visible. Yes, the first 1 hour, once you receive the patient, what has shown to change the outcome, one, doing a quick, good fluid resuscitation, administration of the antibiotic, targeting your MAP of 65 millimeter mercury, starting the vasopressor as early as possible. See, the lactate has got a little weak recommendation. That's why I'm not reinforcing. Also, please, we have to understand that many of the centers, many places will not have even arterial blood gas monitoring. So what we can do, if you have the minimalistic setup with you, fluid resuscitation, early antibiotic, blood culture, vasopressor. This has definitely shown to an early source control. Obviously, it doesn't come within the first 1 hour, but definitely these 4 has been shown to have very good changes in the outcome. All of these actually come with very high level of evidence. So when you go back and see the guidelines, you can see the recommendation level itself will change. It will be very strong recommendation for the antibiotic. We know very clearly that antibiotic is very highly recommended. Similar thing about the fluid. The fluid resuscitation is also very crucial. So remember to reinforce it again, fluids, antibiotics, blood cultures, vasopressors, first 1 hour, you have to get going with it. As you're doing, if you have some source which has to be controlled, you need to remove a focus of sepsis, some abscess is there, you have to call in your surgeon, you have to call your colleagues for help out. It comes definitely, but not in the first 1 hour. The first 1 hour is what you do bedside. Golden hour is all about what you do bedside, what you can do to make the difference. Someone has asked me also about the antibiotic. The choice of antibiotic is very difficult. That's what I'm trying to tell. So when you choose the antibiotic, it is like, is it lung, is it abdomen, is it kidney, is it meningitis? That's how you go. Because if it is lung, the patient is coming for community acquired pneumonia, a simple drug like ceftriaxone, 3rd generation cephalosporin with a macrolide will be more than enough, azithromycin, that's it. You're suspecting abdomen, say there is a cholangitis, a good beta-lactamase inhibitor combination like piperacillin tazobactam would be a good choice of antibiotic. Similarly, if you're suspecting urine, now the urinary tract infection, earlier we used to stick to 3rd generation cephalosporin, but we now know there is rising incidence of ESBL in the community, because of which there is lot of lot of evidence coming regarding the use of even carbapenem for a complicated septic shock UTI patient. So probably carbapenem. Meningitis. The meningitis rarely presents with shock, but if you have someone with meningitis, you will want to consider using ceftriaxone. You will want to consider, if you're suspecting viral cause, you will give acyclovir. So suppose you have a center or you are working abroad where there is large incidence of MRSA, you will still want to give vancomycin. So that's how we divide. It's very difficult to just say that, one antibiotic for all the system. That doesn't happen like that. Now, also the second criteria, as I mentioned, say you have someone who is post-transplant, whatever, bone marrow or solid organ injury, solid organ transplant, whatever. The choice of antibiotic will not be the simple ceftriaxone for pneumonia. You will go for a broader cover. You will give someone like carbapenem. So again, the antibiotic will change. Also, it will change. Suppose your patient was admitted, has been with you in the past 3 months, was admitted, recently discharged. Again, you will want to cover multi-drug resistant infection like Pseudomonas, Acinetobacter. So trying to say one antibiotic, one size fits all, very unlikely. But I think the antibiotic, because all of us are now working in units, we have our own antibiogram. We can use our antibiogram and decide about the antibiotics.
Dr. Meghana, I think this is Dr. Deepak.
Yes, sir.
Very well, like said, and I think very lucidly explained the basic concepts of the sepsis. I think Dr. Subbareddy has requested me to take over the moderation from here.
Sure. Yeah.
He has started in some urgent case.
He did.
One question which one of the critical care register has asked is, I think about the fluid bolus. I think one of the consultant has asked 4 ml per kg to 6 ml per kg. How do you choose? But I presume that is more for the tidal volumes, I think.
I'm not sure. I'm
Yeah.
sure only about 30 ml per kg. Sorry, doctor, I'm not sure where this 4 ml.
Maybe I think it was about the tidal volume challenge.
Oh, okay. So Dr. Deep, I have not touched upon the ventilation. Mechanical ventilation and sepsis is totally different.
Yeah.
I thought I'll just keep it myself.
If you allow me to take that question, I think it is as standard as any other ArtsNet protocol.
Correct, sir. Yes,
and nothing much difference, and it would be a standard ArtsNet protocol management. Another one question which one of the register has asked is the choice of crystallite in the resuscitation. Any points on that? Yes,
sir. So choice of crystallites, there is a lot of evidence regarding fluids. There is a lot of evidence coming about fluids. I wish I had one particular slide. I was trying to make it as simple as possible. It's always balanced crystallite salt solution over the normal saline. Go for go for balanced crystalloid solution, because now there is a lot of evidence. So there was this split trial which came as early as 2015. So in 2015, the split trial left us in splits. What they were telling was, no, there was no difference between the salt and normal saline and balanced crystalloid. But we found that there was a lot of flaws in the study, probably because they was actually not including very critically ill patients. Second, the amount of fluid what they had given was not very high. So that study was left aside. And then we came later, multiple RCTs and meta-analysis, which compared, and they clearly came out saying that you go for balanced crystalloid salt solution as compared to normal saline. Coming to the colloids group, the starches have gone out of question like many years back. The starches have totally gone out of the question many years back. The hexa starch, gelatin, whatever, semi-synthetic, synthetic, whatever it is, it's totally gone out. Coming to albumin, a big no to hyperoncotic albumin, a big no to 20% albumin for sure. Now, there was this study which was comparing, I don't have the chart with me. If we still have time, I think one of my other talks I have where I had taken the, yeah, is my slide still visible? I mean, if so, I can share the few data regarding the fluids. So what they felt was, this particular talk I had given like a few years back. So yeah, so I wanted to show you this. Now, this is the chart which I want to show you. You can see this diamond shape is the hyperoncotic albumin. What they found was there was more incidence of renal dysfunction, more incidence of renal replacement therapy, and ICU death, 28-day mortality. Everything was very high in patients where there was hyperoncotic albumin being used. So it's a big no. But what about if you were to ask me about safe study, 4% albumin? Yes, albumin can be considered. 4% albumin, 5% albumin can be considered. This is as per the Surviving Sepsis 2021 guideline. You anticipate that you have to give some more crystalloids. Consider shifting over to 5% albumin, something which you can do. So the Hess controversy, this is all about the Hess controversy, all the particular YSEP study and many others which have clearly shown that it's a total no to it. But coming to the crystalloids, now we know that it's only a balanced salt solution. Many studies which have come into existence in the recent time. After the split trial, we had the most recent trial, which was also showing that balanced salt solution is better. So, unfortunately, I don't have one summary slide. I wish I had kept one of those. I think I should have kept. Yeah, but this is the evidence. There are a lot of studies on each of these. The colloids is a separate topic. Colloids versus crystalloids was compared. Crystalloids versus crystalloids was compared. And now we have come down to the fact that it's only balanced crystalloid salt solution, and using only balanced crystalloid salt solution. Maximum after that, we can use, what you can use is a 4% albumin or 5% albumin if you're wanting to continue the resuscitation based on the dynamic parameters. Yeah, these are the slides which show that balanced crystalloids is better. Any other doubts? Can take questions till 4:30, I think. Dr. Deepak, any other questions? Any other questions, Dr. Deepak? I mean, I'm just seeing the chat box.
Yeah, I think, yeah, they just unmuted me.
Oh, okay.
So,
okay.
yeah, as I think you rightly said, I think sepsis is not a new thing for us, and it's going to stay with us. It may come in new forms, like you can have a de novo sepsis coming to the emergency where it's a crystal clear concept what to do and all. Or you can have a sepsis in a patient who's admitted with a stroke in your ward. Then you need to recognize the new sepsis, nosocomial sepsis, and you need to resuscitate him. So wherever it is, I think you need, any beginner, whether it's a nurse or whether in an intensivist, you need to have to think about the possibility of the sepsis. As you rightly said, use the SOFA score, the basic criteria, how to identify it. Then I think the resuscitation, as you again rightly said, I think monitoring aspect, the basics of monitoring like capillary refill time,
Yes.
which is the most common thing and easily missed. Rather than going and pricking the patient for the arterial blood, I think if you can manage you can monitor the capillary refill time, which is very easier one.
True.
And
Very
if you can concentrate on hourly urine output, I think that would be even in a resource limited setting, I think you can do justice to this patient. And second thing is the fluid. Again, rightly said, I think normal saline is not really normal. So you should not dump so much of normal saline. The concepts are clearly evolving. I think last week again another study came, plus study, where they again told that normal saline is equal to balanced crystallite. So it's going to evolve. But the point is, you can consider albumin, but just because albumin is a costly fluid, it doesn't mean that it is better than your crystallite fluids. And go for an early resuscitation rather than late resuscitation, because once you have a late shock, the possibilities of resuscitating the patients are low. So don't go on waiting for the central line to start an noradrenaline or something like that. You can still start low doses in the peripheral lines. Antibiotics, the choice, and I think it was very clearly explained by the prior speakers that you need to know your antibiogram of the hospital and your local community. For example, your choice of antibiotics depends on the source of infection, antibiogram as well. And if you give that antibiotic in a proper time, that is the quintessential one which is going to save your patient. I think excellently done by both the speakers. If any other questions are there, kindly I would invite. If there are no further questions, I think we can sign off. So the next webinar would be on 2nd of March. It is another important topic, approach to hypotension. So it is both important for all the specialties, either from whether you're working in an intensive care unit or ER or in the ward. So kindly stay tuned. Thank you, Dr. Meghna. It's a pleasure to hear to you. And thank you, Mrs. Kala. Thank you.